My name is Michelle Ndwele, and I'm the Senior Director for Health Promotion with the Arthritis Foundation. It is my pleasure to talk to Dr. Dan Claw. Dr. Claw is the Director of the Chronic Pain and Fatigue Research Center and a Professor of Anesthesiology, Rheumatology, and Psychology with the University of Michigan. Welcome, Dr. Claw.
How are you?
Great, thank you. All right, so Dr. Claw, I'm an arthritis patient, and we tend to talk about pain in general terms. But effective pain management is all about the source or the cause of the pain. So let's talk about some of the terms. There is nociceptive, neuropathic, and nociplastic. What do those terms mean?
So nociceptive pain is the type of pain that I think most people think about. You burn your finger or you hit your thumb with a hammer. There's some sort of damage or inflammation in that region of the body and you feel pain. And that has an adaptive purpose to move away from whatever was injuring you. And that, again, almost all types of acute pain are really nociceptive pain. The second category of pain mechanism that we've known about for a long time is neuropathic pain or nerve pain. You have a pinched nerve in your back like sciatica or in your wrist like the carpal tunnel. And that causes carpal tunnel syndrome or sciatica because there's nerves that are pinched or damaged, and that causes pain. But the third category, nociplastic, is a really new category that just really was voted on formally by the International Group of Pain Researchers a couple of years ago. And this is a mechanism where we think the central nervous system is really causing the pain. And in a analogy I've been using for a long time to explain this to patients and providers, we think that the pain processing is a lot like an electric guitar, and there's two ways to make an electric guitar louder. You can either strum the strings harder or you can turn up the amplifier. And in this third kind of pain, nociplastic pain, it seems to be more of an amplifier problem, that the problem is really more in the central nervous system. It's amplifying pain signals and other sensory signals, because one of the sets of symptoms that we know we see in nociplastic pain is that people are not only more sensitive to pain, they're more sensitive to the brightness of lights, the loudness of noises, odors, any type of sensory stimuli, because the same brain regions like the insula that code for how pain sensitive you are also typically code for how more globally sensory sensitive you are. So in that third type of pain, nociplastic pain, the key features are that people are pain sensitive, and we used to look for tenderness when we looked, for example, at tender points in fibromyalgia, but we don't rigidly do tender point counts anymore. We recommend that on physical exam, people assess for tenderness. But the key symptoms of nociplastic pain are that the pain is more widespread. It involves several different regions of the body, not just one or two regions of the body. It's accompanied by other symptoms that come from the central nervous system, like fatigue, memory problems, and sleep problems. So we look for fatigue, sleep, and memory problems in combination with multifocal pain. And that really is the type of pain mechanism, the third pain mechanism, that we really have just begun to understand over the last couple of decades. And we know that regardless of whether someone has rheumatoid arthritis or osteoarthritis or low back pain, if their pain's coming from that third mechanism, the types of treatments that are going to work are going to be quite different. Surgery, injections are not going to work for nociplastic pain because surgery or injections are aimed out at the peripheral tissues, and this pain is more of an amplifier problem. It's more of a central nervous system problem.
So it sounds, Dr. Claw, that for someone with rheumatoid arthritis, they could be experiencing pain from all these three sources. So they could have nociplastic, neuropathic, and nociceptive pain. Is that correct?
Exactly. Yeah, and that's a big change. We used to think that, when we said rheumatoid arthritis, we would say, well, all the pain in rheumatoid arthritis is nociceptive because there's an autoimmune disease causing inflammation. So that's where all that pain is coming from. But we know that 40 or 50% of patients with rheumatoid arthritis, psoriatic arthritis, where we really had major advances in our biologics and our therapy that can reduce inflammation. 40 or 50% of people still, after we reduce their inflammation quite well with those drugs, have residual pain and fatigue and memory problems and sleep problems. And often that is because they do have that other mechanism of pain that hasn't been identified and treated yet. People are really just focusing on the nociceptive elements of their pain and the pain that is due to ongoing damage or inflammation. These integrative therapies, again, things we used to call alternative therapies, can be helpful for any type of chronic pain, but they seem to be particularly helpful for these nociplastic pain conditions because they are, as you said earlier, sort of mind-body therapies in many cases.
So is it also the case that with patients with osteoarthritis, they may not be at the stage where they actually need joint surgery, but because of the focus on just their joint pain and not thinking of the other sources, that they have surgery and are still experiencing pain? Is that also the case for people with OA?
Absolutely. And again, we know that there's a sizable number of people with OA that have superimposed nociplastic pain. And again, they may not benefit nearly as much from joint replacement surgery. They actually may benefit a lot more from drug and non-drug therapies that are attacking their amplifier, trying to reduce their central nervous system pain sensitivity and some of these other symptoms that are coming more so from the central nervous system. So there's a different set of drugs that you might use for those people. You certainly keep opioids away from people with this kind of pain, nociplastic pain, because they don't work for this kind of pain. And again, there are some drugs that can be helpful, but we especially embrace the use of these non-pharmacologic therapies that can really be, because they might be attacking some of the core problems. We know that nociplastic pain might be caused in part by when individuals develop chronic pain, they become inactive and they become sedentary, but we know physical activity makes people less pain sensitive. The more active they are, the lower their amplifier setting. So in some cases, we're really just trying to use sort of holistic strategies, get people active and even doing a little bit of exercise, really focus a lot on sleep, getting people sleeping better. We're realizing how important that is across chronic pain states. But really focusing on some of those key body functions and then adding on some of the integrative therapies that can really be helpful in getting people sort of to the next step with respect to pain control. But again, what we're really focusing on more so than pain control is allowing people to function better and to be able to do some of the types of things that they can't do once they develop chronic pain, but focus on what are those functional goals and help get them to attain those goals, again, especially by adding some of these integrative therapies to their regimen.
That's a great segue for us to talk a little bit about some of these therapies. So let's start off with acupuncture and acupressure. Could you share what we know with regard to evidence and how they can help different types of arthritis?
So I'll tell a really quick anecdote. Very early in my career, when I was still at Georgetown, a PhD named Rick Harris called me on the phone. We had just received one of the first NIH R01 grants to study acupuncture because there was a new institute that was created at the NIH called NCAM. And he saw that Georgetown did a press release that we got this grant, and he called me and he asked if there was a role on the grant for him. And he was a PhD trained neuroscientist, but he really wanted to learn how to do research in acupuncture. So he started out as a study coordinator. A month or so ago, he became a fully tenured professor at the University of Michigan. But he's had an incredible career in showing not just that acupuncture and then acupressure could be effective for treating a number of different chronic pain states, starting with fibromyalgia, but going on from there. But he's also now one of the leading pain brain imagers in the world and done brain imaging studies to help show how and why acupuncture and acupressure might be working. Something that I really was taught in my early training when I was trained at Georgetown as a rheumatologist, that a lot of these Eastern therapies were, couldn't work at all. They yoga, Tai Chi, acupuncture, and now 30 years later, I'm at an ACR meeting talking to people about how well they work and that these are really some of the mainstays of therapy. So anyway, I tried to go through that history there, talk about acupressure, some of the early thinking about acupuncture, acupressure, and now again, some of the studies or the data, that now Medicare approves acupuncture for knee osteoarthritis. That's how far we've come with respect to the evidence base for not just acupuncture, but for, again, many of these non-drug therapies.
Excellent. All right, Dr. Claude. So let's talk about some of the other mind-body therapies. There are so many acronyms that people are unfamiliar with. So let's see if we can do some clarification for them. So there's CBT, which is cognitive behavioral therapy, and there's ACT, which is acceptance commitment therapy. Could you explain what those two therapies entail and how they can help?
Yeah, so cognitive behavioral therapy is an older term that really encompasses a number of strategies, some of which can be entirely taught via self-management techniques, but originally cognitive behavioral therapy was typically given by someone that was a trained therapist, usually a psychologist. And there were a lot of different things under the umbrella of cognitive behavioral therapy, stress reduction techniques, pacing techniques, a number of techniques, but these were all trying really to get people to be able to reduce their pain in a number of different ways. There usually CBT also included some activity or even some exercise under the umbrella of cognitive behavioral therapy. But then over time, psychologists took more nuanced views of different sort of forms of cognitive behavioral therapy, and one that was developed about 10 or 15 years ago called acceptance and commitment therapy takes a slightly different approach and gets individuals with chronic pain to acknowledge that in most instances, the pain will be chronic. They're likely to continue to have some pain, but they can functionally still do quite well in spite of that, using some of the strategies that are taught in ACT. But there are other types of, if you will, derivatives of cognitive behavioral therapy, including one emotional acceptance therapy that we tested in a trial with Mark Lumley and Howard Schubner that might be especially helpful in people with chronic pain that have had a lot of trauma in their lives. This is a specific type of therapy where the patient is asked about that trauma, helped work through the trauma. And again, in a small subset of people with chronic pain in whom this is a problem, individuals can have fairly dramatic responses to that, again, specialized type of, if you will, cognitive behavioral therapy.
Oh, I see. All right, so let's talk a little bit about mindfulness and meditation, because those terms are used interchangeably. Is that correct? And how should people think about using these therapies for their arthritis symptoms?
To a layperson, there's a lot of similarities between mindfulness and meditation, but to the individuals that sort of teach those, they're quite different. There's a number of techniques that have been used for people to meditate. It's different types of relaxation techniques, whereas mindfulness is a very specific mindfulness-based stress reduction. People go specifically to courses to learn exactly how that's done. And it really is a specific type of, if you will, and the people who teach this might not agree with this, but I would say it would fall under the umbrella of different sort of meditative practices, but it's a very specific one that has actually been studied a lot in trials. And because of that, it's widely used because it has been shown to be effective in a number of different types of chronic pain, the specific MBSR, mindfulness-based stress reduction.
Okay. So let's close out this discussion around talking about biofeedback and clinical hypnosis. I know a lot of patients have heard of hypnosis, but I noticed the term clinical hypnosis is relevant. So could you explain what that means?
Well, so clinical hypnosis uses the same concepts as that what people would understand as hypnosis, except obviously it's trying to aim towards a clinical end. So the focus really is not on, hypnotizing people like you see on TV shows, but rather to get them to think in different ways and to not really think as much about being in pain as they might otherwise think about. So that is how it's used clinically. Biofeedback, there's just a number of different ways in which you can hook people up to devices that allow them to see how their body is functioning. Usually these devices are in some way measuring the autonomic nervous system, the fight or flight response, and picking up on, for example, if galvanic skin resistance, if people are sweating a little bit more, or heart rate. But using different types of biofeedback, there's even now neuro biofeedback where people are looking at a EEG tracing of their own mind. It allows people to see that they're having stress or that they are activating their sympathetic nervous system, and then practice different types of techniques that could sort of reduce that. But it's basically giving a feedback to the person of what's going on in their body, and in particular, maybe their mind, and allowing them to practice a number of different relaxation techniques to help mitigate against that sort of sympathetic response, that arousal response that in some individuals will cause flares of their pain.
So in closing, Dr. Claw, how would you recommend for an arthritis patient, whether with their rheumatologist or their primary care doctor, to explore some of these non-drug therapies as a part of their comprehensive plan?
So I think that for anyone with chronic pain that really is trying to get better, I mean, some people with chronic pain have, sort of succumbed and say, okay, I am who I am. I'm not going to try to make my pain or my functional status better. But for the individuals that want to get better, my biggest advice to them is try 2 or 3 of these non-pharmacologic therapies that you've never tried this year. Acupuncture, yoga, Tai Chi, massage, chiropractic manipulation, mindfulness, meditation, CBT, ACT, all of these things that we've talked about and more that are under the sort of umbrella of non-pharmacologic therapies, a number of movement-based therapies. Just become a little bit more active. Don't get threatened by the term exercise. The more active you can become, the better your pain levels, the better your fatigue levels. But my challenge to an arthritis patient would be to say, try 2 or 3 of those new treatments that you've never tried before, because the evidence is that they work well in about 1 out of 3 individuals. That's like a lot of our drugs and a lot of our non-drug therapies only work in about 1 out of 3 individuals. But if you try 3 new non-drug therapies this year, you may find one that really works well in you that you keep doing because it really is the one, just like you find a drug that works well for you. So embrace the fact that you actually, as a patient, have the power to improve your pain, improve your functional status. But instead of going to your doctor this year and asking for a new drug for pain, pick a new treatment from that list that we've been talking about and try something you haven't tried yet to see that if it might be helpful in you. Because when you find that non-pharmacologic treatment, I can't ever tell who's going to respond to yoga, who's going to respond to acupuncture, acupressure. We're doing studies now. The NIH is funding studies now looking at that. But right now, all we can do is sort of plead with our patients, try some of these therapies. You might be surprised, just like I am surprised 30 years after I was trained at Georgetown as a rheumatologist that, things like acupuncture, yoga, chiropractic manipulation did not work. And, we should never be recommending that to our patients. 30 years later, the scientific evidence has changed. And so I've changed, and patients similarly probably have some antiquated views about, how effective these therapies are. And they should try these things. They might be surprised at how effective they might be.
Dr. Claw, thank you so much for taking the time to talk to us today.
Thanks for having me.